Pain is not just in your head. It's your body's way of shouting, "Hey, pay attention." Pain is a universal human experience and one of the most complex sensations our body processes. It serves as a protective mechanism, alerting us to potential injury or illness. But what exactly happens in the body when you feel pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It's subjective, meaning no two people perceive pain the same way. While it's unpleasant, pain is essential for survival as it warns the body of harm and prompts protective actions. How pain works? Pain follows a systematic process involving detection, transmission, and interpretation. First, nociception, or recognizing the pain. Pain starts with specialized sensory receptors called nociceptors, located in various tissues like skin, muscles, joints, and organs. These receptors are designed to detect harmful stimuli. Stimuli that activate nociceptors are varied: mechanical, such as pressure from a cut, scratch, or injury; thermal, such as extreme temperatures, burns, frostbite; and chemical, such as inflammatory substances, including prostaglandins, histamine, or toxins from injury or infection. When stimulated, nociceptors convert these harmful stimuli into electrical signals that initiate the pain pathway. Second, transmission or sending the pain signals. Once nociceptors are activated, the electrical signals travel along nerve fibers toward the central nervous system. Certain types of nerve fibers are involved in pain transmission. A delta fibers are fast conduction fibers responsible for sharp, immediate pain, such as a needle prick. These fibers help your quick response to potential threats. While C fibers are slow conduction fibers responsible for dull, throbbing, or chronic pain. They are often associated with discomfort lasting long after the initial injury. Pain signal relay occurs in the brain as signals from nociceptors travel to the spinal cord, entering through the dorsal horn. Here, the signals are processed and relayed upward to the thalamus, a sensory relay center in the brain. Third, interpretation or decoding the pain. The brain processes pain in various regions, translating the electrical signals into an actual experience of pain. The main areas of the brain involved in pain perception are usually in the cerebrum. 1. The somatosensory cortex. This determines the location, intensity, and quality of pain, such as sharp or burning. 2. The limbic system. This adds an emotional response to pain, such as fear, anxiety, or discomfort. This explains why pain often feels worse when you are upset or stressed. 3. The prefrontal cortex. This handles your response to pain, influencing how you cope, rationalize, or suppress the sensation. Why do we perceive pain differently? Pain perception is a deeply personal experience shaped by a combination of biological, psychological, and social factors. These influences are collectively explained by the biopsychosocial model, which underscores that pain is not purely a physical sensation, but a complex interaction of multiple elements. First, genetic factors. Certain genetic variations can influence how pain signals are processed and modulated in the body. For instance, changes in genes related to opioid receptors, such as the OPRM1 gene, affect sensitivity to natural pain relievers such as endorphins, and exogenous opioids such as morphine. Genetic differences in pain-related ion channels like SCN9A can alter nerve sensitivity, making some individuals more or less prone to pain. For example, people with a rare condition called congenital insensitivity to pain caused by SCN9A mutations cannot feel pain, highlighting the role of genetics in pain perception. Conversely, certain gene variants make some individuals more prone to conditions like migraines or fibromyalgia. Second, mood and emotional state. Stress, anxiety, and depression can heighten the perception of pain by overactivating the brain's pain processing centers, such as the amygdala and prefrontal cortex. Chronic negative emotions also lower pain tolerance by reducing the brain's production of endorphins, the body's natural painkillers. Happiness, relaxation, and a sense of well-being can reduce pain perception. Positive emotions stimulate the release of dopamine and serotonin, which counteract pain signals. Practices like laughter therapy or mindfulness are often effective for managing chronic pain. For example, people under stress often report higher levels of pain during dental procedures or medical treatments, while athletes may feel less pain during competition due to adrenaline and focus on the task. Third, past experiences with pain. The brain stores and recalls past pain experiences to prepare for similar future events. This memory can either heighten or dull future pain perception, depending on the context. Repeated exposure to pain can lead to pain sensitization, where the nervous system becomes hyperreactive to even mild stimuli. Negative past experiences can lead to fear of pain, causing people to anticipate it as worse than it may actually be. This mental focus can amplify the pain experience. For example, a child who experienced a painful vaccination may associate future needles with heightened fear and pain, while someone who regularly exercises might experience less pain from muscle soreness due to familiarity with the sensation. Lastly, cultural and social norms. Different cultures approach pain expression and tolerance differently. For example, Stoic cultures encourage enduring pain silently, which may result in a perception of greater tolerance to pain, whereas expressive cultures encourage expressing pain openly, which may result in an increased awareness of it. Social support may also reduce pain perception, as the presence of empathetic individuals can reduce stress and enhance coping mechanisms. Conversely, social expectations such as "real men don't cry" may influence the way people perceive and report their pain. Studies show that women often report pain more readily than men due to differences in cultural norms about emotional expression. Ritual practices such as firewalking or piercing in some cultures demonstrate how cultural context can shape pain perception. These factors don't act independently but interact dynamically. Someone with a genetic predisposition to pain sensitivity may still experience less pain if they have strong social support or a positive mindset. Conversely, chronic stress or depression can worsen pain regardless of an individual's physical condition. So pain perception is not a one-size-fits-all experience. How does the brain modulate pain? Pain perception is not a passive process. The brain plays an active role in controlling and modulating pain signals through various mechanisms. Pain modulation refers to the process by which the brain and nervous system control, enhance, or reduce the intensity of pain signals being transmitted throughout the body. While the nociceptive pathway, or the pain signaling pathway, transmits pain from the site of injury or inflammation to the brain, pain modulation determines how we actually perceive the pain. These pathways help the body manage pain more effectively, sometimes even without the need for external treatments. In essence, pain modulation is the brain's ability to control how much or how little of the pain signal we experience. This involves both descending pathways, or the signals going down from the brain to the body, and ascending pathways, or the signals traveling from the body to the brain. The brain's influence on pain is a complex interaction between various systems, including the spinal cord, brainstem, and cortex. First, descending pain inhibition. The brain can actively send signals down through the spinal cord to inhibit pain. This is done via the descending pathways, particularly through structures like the preaqueductal gray in the brainstem. These signals release endorphins and enkephalins, which bind to opioid receptors in the spinal cord, dampening the pain signals before they reach the brain. Endorphins are natural neurotransmitters produced by the brain and nervous system. They are part of the body's intrinsic pain relief system and act similarly to opioids. Endorphins bind to opioid receptors in the brain, blocking the transmission of pain signals and reducing the sensation of pain. In addition to their role in pain reduction, endorphins also promote feelings of well-being and euphoria, often referred to as the runner's high. This mechanism is why activities like exercise, laughter, or social bonding can improve mood and reduce pain perception. Endorphin release is crucial for the body's ability to manage pain naturally. It is activated by both physical activities like exercise or physical therapy and psychological states like laughter or relaxation. Second, gate control theory. The gate control theory of pain, proposed by Melzack and Wall in 1965, suggests that non-painful stimuli can inhibit the transmission of pain signals to the brain. The theory posits that pain signals are transmitted through a gate in the spinal cord, which can be opened or closed based on the type of signals coming from the body. According to this theory, when you experience a non-painful stimulus, such as rubbing a sore spot or applying heat or cold to an injured area, these sensations can close the gate at the spinal level, reducing the intensity of the pain signals being sent to the brain. This helps to block or reduce pain perception. The gate control theory explains why certain activities, such as massaging a muscle spasm or applying a heating pad to a sore joint, provide relief from pain. It also highlights the importance of sensory distraction in managing pain, whether through physical methods like touch or through psychological methods like focusing on something else. Third, central sensitization. This occurs when the brain's pain processing centers become hypersensitized after a prolonged period of pain, causing an exaggerated pain response even to stimuli that wouldn't normally be painful. Conditions like fibromyalgia or chronic pain syndromes are linked to this phenomenon, where the brain becomes overly responsive to pain signals. For example, after an injury, the brain may remember the pain and continue to interpret normal sensations like a light touch is painful due to sensitized pathways. Fourth, top-down processing. This concept refers to how our thoughts, emotions, and expectations influence the perception of pain. The brain can amplify or dampen pain based on psychological factors like mood or fear. Cognitive factors like expectations and attention can increase or decrease the perceived pain intensity. For example, if you're highly anxious about a medical procedure, the brain can make you feel more pain, even if the procedure is relatively minor. On the flip side, if you're distracted or have a positive expectation, pain might feel less intense. So brain's ability to modulate pain is not limited to physical mechanisms. Fifth, placebo effect. The placebo effect is a powerful example of the brain's ability to modulate pain. When a person believes they are receiving a treatment, even if it's a sugar pill, the brain can produce physical changes in the body that reduce pain. This is thought to involve endorphin release and activation of brain regions associated with pain relief. For example, a person who receives a placebo for pain relief might report feeling less pain simply because they believe the treatment is effective, highlighting the brain's influence on pain perception. This demonstrates the powerful mind-body connection in pain management. In essence, the brain's role in pain modulation is an intricate and dynamic process. These built-in processes highlight the importance of both physical and psychological factors in pain management, and understanding them can help improve pain management strategies in both clinical and everyday settings. Now let's discuss the types of pain. Pain serves as the body's alarm system, signaling potential harm or injury. However, not all pain is the same, and understanding the different types helps in diagnosing and treating it effectively. First, acute pain. Acute pain is a short-term, immediate response to an injury, surgery, or illness. It serves a protective function, warning the body of harm and initiating healing processes. It usually begins suddenly and has a sharp quality. It is proportional to the cause, meaning that more severe injuries cause more intense pain. It resolves as the injury heals, often within a few days to weeks. This type of pain activates the body's fight or flight response, leading to symptoms such as increased heart rate and blood pressure. Causes include cuts, burns or bruises, broken bones or sprains, post-surgery recovery, and dental procedures such as tooth extractions. Acute pain can be managed with over-the-counter pain relievers such as ibuprofen, acetaminophen, or prescription medications. Second, chronic pain. Chronic pain persists for more than 3 to 6 months, often extending beyond the expected healing time. It can result from an injury, illness, or an unknown cause. Unlike acute pain, it serves no protective purpose and can negatively impact quality of life. It may be persistent or intermittent, such as coming and going. It is often accompanied by fatigue, mood disturbances, and decreased physical function. This type of pain is associated with central sensitization, where the nervous system becomes hypersensitive to pain signals. Common causes include arthritis, fibromyalgia, migraines, and nerve damage that occurs after trauma, surgery, or conditions such as shingles. Management usually depends on the specific type of cause. Third, neuropathic pain. Neuropathic pain occurs due to damage or dysfunction in the nervous system. It causes a burning, prickling, or electric shock-like sensation. It can also occur spontaneously without any obvious trigger. It is often chronic and difficult to manage. Causes include diabetic neuropathy, post-herpetic neuralgia caused by the herpes zoster virus, spinal cord injuries that disrupt nerve signals, and multiple sclerosis. This type of pain doesn't respond well to traditional painkillers and often requires specialized treatments. It is usually managed with medications such as gabapentin, pregabalin, or duloxetine. Fourth, nociceptive pain. Nociceptive pain arises from actual or potential tissue damage. It involves the activation of pain receptors or nociceptors in response to physical injury or inflammation. Its causes include physical injury, inflammation or infection, and stretching or cramping of organs during childbirth. It can be somatic or visceral pain. Somatic pain originates from the skin, muscles, bones or connective tissues, and is acute, localized, and easily identifiable. For example, a sprained ankle or a cut on the hand. Visceral pain, on the other hand, comes from internal organs such as the stomach, liver, or bladder and is dull, aching, and often difficult to localize. It is associated with conditions such as appendicitis, menstrual cramps, or gallstones. This type of pain is usually managed with NSAIDs in mild cases and opioids in severe cases. Lastly, psychogenic pain. Psychogenic pain refers to pain influenced or exacerbated by psychological factors like stress, anxiety, or depression. While it has no clear physical cause, the pain experienced is real and can severely affect the individual. It can occur simultaneously with physical pain conditions, making diagnosis challenging. It tends to worsen during periods of emotional distress. Examples include tension headaches resulting from chronic stress, muscle pain associated with anxiety, and chronic fatigue syndrome with psychological and physical components. This type of pain is managed with a holistic approach, including psychotherapy, relaxation techniques, and medications to manage underlying mental health conditions. It is important to understand the types of pain because each type of pain involves different mechanisms and requires customized treatment. Do neurotransmitters have a role in pain? Yes. Neurotransmitters play a vital role in the transmission and modulation of pain within the nervous system. They act as chemical messengers, carrying pain signals from one nerve cell to another or modulating these signals to amplify or suppress pain. First, substance P. It is a key neurotransmitter in amplifying pain signals at the spinal cord level. It is released by sensory nerve endings when nociceptors are activated by injury or harmful stimuli. It binds to specific receptors in the spinal cord, NK1 receptors, enhancing the transmission of pain signals to the brain. Clinical relevance. High levels of substance P are often associated with chronic pain conditions such as fibromyalgia and arthritis. Drugs targeting NK1 receptors are being developed to reduce pain. Second, glutamate. Glutamate is the primary excitatory neurotransmitter in the nervous system, crucial for transmitting pain signals to the brain. When released at synapses in the spinal cord, it binds to NMDA and AMPA receptors, facilitating the transmission of pain signals. Clinical relevance: excessive glutamate activity can lead to hyperalgesia or increased sensitivity to pain and contribute to chronic pain conditions. NMDA receptor antagonists like ketamine are used to manage severe or chronic pain. Third, endorphins and enkephalins. Endorphins and enkephalins are natural opioids produced by the body to suppress pain. They work by binding to opioid receptors in the brain and spinal cord, inhibiting the release of excitatory neurotransmitters like substance P and glutamate. This blocks the transmission of pain signals to the brain. Clinical relevance: activities like exercise and laughter can increase endorphin levels, providing natural pain relief. Synthetic opioids mimic their action, but carry a risk of addiction and side effects. Fourth, serotonin. It plays a dual role in pain perception and modulation. In the spinal cord, serotonin can inhibit pain transmission by enhancing the effects of enkephalins. However, in some cases, it can amplify pain signals depending on receptor type and location. Fifth, dopamine. It is primarily involved in modulating the emotional aspects of pain. Dopamine helps reduce the perception of pain by influencing reward and pleasure pathways, often counteracting the distress associated with pain. Clinical relevance: low serotonin and dopamine levels, often seen in depression, are linked to heightened pain sensitivity. Medications like serotonin norepinephrine reuptake inhibitors or SNRIs are used to treat chronic pain and associated mood disorders. How are pain and inflammation connected? Pain and inflammation are tightly linked, as inflammation often triggers or worsens pain. Inflammation is a protective response by the body to injury, infection, or harmful stimuli, and it activates several pathways that contribute to pain. How inflammation amplifies pain? Inflammatory chemicals such as prostaglandins and cytokines sensitize nociceptors. This lowers the threshold for nociceptor activation, making them more sensitive to stimuli. This explains why even a light touch may feel painful in inflamed areas. Repeated or prolonged exposure to inflammatory chemicals can lead to peripheral sensitization, where nociceptors become hyperactive. This can progress to central sensitization, where the spinal cord and brain amplify pain signals, contributing to chronic pain syndromes. Why pain accompanies inflammation? The hypersensitivity caused by inflammation is an evolutionary protective mechanism. Purpose: pain ensures that the injured or infected area is protected while healing occurs. For example, if a sprained ankle is painful, you're less likely to put weight on it, preventing further damage. Clinical relevance: in chronic conditions like rheumatoid arthritis, ongoing inflammation leads to persistent pain, even when the protective role is no longer beneficial. Finally, some interesting facts about pain. The brain itself cannot feel pain, as it lacks nociceptors. Women generally have a higher pain tolerance than men, likely due to hormonal differences. Chronic pain affects 1 in 5 adults worldwide, making it a significant public health issue. In essence, pain is more than just a physical sensation. It's an intricate interplay of biology, psychology, and personal experience. While it's a necessary part of survival, chronic and poorly managed pain can significantly impact quality of life. By understanding the science of pain, we can develop better ways to treat and alleviate it, giving hope to millions who suffer daily.